Dr. Brandon,
Dr. Morgentaler,
great to see you. It's another episode of
the sex doctors.
Sex Doctors,
That would be,
you and me.
yeah,
Yeah. So, I've got an article for us to talk about today.
excellent.
It's on my favorite topic, which is testosterone, and my favorite subtopic, which is testosterone and prostate cancer.
Yes.
So this just came out.
Before we start, a small disclaimer. The Sex Doctors podcast is not a substitute for medical or psychological advice.
This is a study, the author, it's called Low Testosterone Level and Mortality Risk in Patients with Prostate Cancer. And the senior author is Anthony D'Amico, who is a major figure in the radiation therapy world of prostate cancer.
Do you know him?
We've met, but he, in the whole prostate cancer world in Boston, he's at the Brigham and Women's Hospital and the Dana-Farber Cancer Institute. He's been a major player. A lot of things, some things are named after him,
Wow.
like severity of disease, that you get a D'Amico score.
Wow.
And so what's really interesting about this is that the world is shifting
Mm-hmm.
in its understanding of testosterone and prostate cancer.
And why might that be?
And and where
Might it be
and
because you have been talking your ass off for the last decades about the fact that testosterone is not the evil substance that causes prostate cancer?
that's very, very kind of you, Dr. Brandon.
And it's correct.
Thank you. I could never say anything like that, but listen, it's been a lot of work to try and disabuse people of the idea that high testosterone is dangerous. When I was I was just talking about this the other day. When I was in my training in the 1980s, I was taught, and nobody questioned it, that if a man received an injection of testosterone today, a healthy man, no prostate cancer, he would be back within a month with aggressive prostate cancer.
That's amazing.
And no surprise then, now somebody listening today, even if you're in medicine, will say that doesn't make any sense. But nobody was getting the reason it could survive like that, persist, is that we weren't treating anybody with testosterone.
Right.
The prohibition, the fear was so great that everybody believed it, therefore nobody treated with testosterone.
I just have to ask you, didn't they do animal studies, like, and see if the animals got prostate cancer?
So very few animals get prostate cancer. As a matter of fact, one of the few is old dogs. Just like humans, old dogs get prostate cancer. But other laboratory models, they don't normally.
Why? Like rats, they don't get prostate cancer?
Rats, as a rule, don't get prostate cancer.
Why not? Don't they have a prostate?
They do have a prostate. Their prostates are somewhat different. Like a rat prostate has 3 lobes. Human prostate is really just one structure.
Huh.
So there's some differences, between different experimental animal models. And the original story about how testosterone was bad for the prostate came from Charles Huggins, 1941, published his landmark paper, a couple of papers, together with his co-author Clarence Hodges. Huggins went on to win the Nobel Prize 25 years later. And in his study, what he showed was that if you took men with metastatic prostate cancer, it's already spread to the bones in that case, and you removed the testicles, castrated these men, that a blood test called acid phosphatase improved. They didn't have PSA back then, which is what we use now. But they work in the same direction, although PSA is a far better test than acid phosphatase, which is why we don't use acid phosphatase anymore. So he showed if you castrated men, acid phosphatase goes down. He claimed that if you gave testosterone injections, acid phosphatase rose. And he came to the conclusion that testosterone injections activate, that's the word he used, prostate cancer. And that was the start of it all. Where did Huggins get his idea? He got it from work in dogs. So urologists have been interested in prostate not only because of prostate cancer, but also because of what we call BPH, benign prostatic hyperplasia. Bigger prostates cause urination symptoms. As guys get older, they wake up at night, they have weak streams. Some of them can't urinate at all, and they get operations. So it had been shown around the turn of the last century, the beginning of the 20th century, that you could castrate men who had urinary obstruction, they couldn't urinate. Their prostate shrunk and they would urinate again.
Okay, so they couldn't urinate. You remove their testicles, or
which the
however
source
you
of
castrated,
testosterone, yeah.
right? And then they could pee again,
And that's exactly how you castrate them, by the way, is
unless you give them
you
drugs,
remove the
right?
testicles.
Okay.
Today we have drugs, but those drugs only appeared really in the 1980s.
Okay.
Yeah.
So they had to have their testicles removed, and then they could
And
pee.
some of those guys peed again. So Huggins was doing research in dogs, discovered that some of these, when they looked at slides of the prostate tissue, that the dogs had what looked like prostate cancer in humans, some of them,
Mm-hmm.
and that castration caused those tumors to shrink too.
So interesting. So you remove the testicles, meaning remove the testosterone from the body, and the tumors shrunk for the dogs, and the prostates shrunk for the guys.
And he was inspired to try it in men, and it helped. And it helped.
Well, that's a very
Interesting little aside is he wasn't the first to do it.
huh.
Most people don't know, most urologists don't know this. So uh, Huggins, there's in some of the old papers, like they're presented at meetings,
Mm-hmm.
and then there's a question and answer period,
Mm-hmm.
and those question and answers were transcribed or edited and added to the actual paper of the presentation. And in one of them,
Oh,
there's some
isn't that interesting?
yeah,
That's kind of cool. They should still do that today.
and in one of them, there's some back and forth. And Huggins said, and they're giving a lot of credit to Huggins for describing this that he wrote about. And he says, well, actually, the first person to do it was this guy, Hugh Hampton Young, who was the first great urologist. Who was very senior by the time Huggins was doing this.
He had a hyphenated last name.
It's not hyphenated,
Oh, okay.
but we always include Hugh Hampton Young.
Yeah.
He's never Hugh Young, Hugh Hampton Young. And we have awards in urology named after him. And he tried it in 2 men,
Uh-huh.
and it didn't work for them.
Oh, he took their testicles off?
Yeah, and their prostates didn't get better. And
What a bummer.
but yeah.
Like,
Yeah,
really?
yeah, I know. That's all side effect, no benefit.
Oh,
Yeah.
and that's not any small side effect. That's like,
But you know what's interesting then is that what a lot of people don't realize is we often talk in generalities. So yes, androgen deprivation, which we can do either by castration or by giving medicines, we say it's beneficial for treating men with advanced prostate cancer, but there's some men who do not respond. It's a relatively small
what
portion.
percentage? Because it seems to me that just about everybody I've ever worked with that had prostate cancer went through androgen deprivation. Like it's like
Well, no,
almost
no.
universal, right?
So really, we only give it today in 2 circumstances. One is men who have spread of their cancers, metastatic disease, pretty much. Some local tumors may be very large, and they may get it before they get surgery. But the second most common thing is together with radiation.
Yeah.
In that case, it's given for a limited period of time.
Uh-huh.
Most commonly now is 6 months, although in the past it was a year or 2, and there are some circumstances where people give it longer still. But those are the 2 main reasons. But if somebody has a localized prostate cancer, which means, as far as we know, it hasn't spread, their 2 usual main treatments are surgery or radiation, and they don't get anything else. But if they get radiation, they might get it for a limited period of time.
Oh, okay. Wow.
Yeah. So anyway, that's the long the backstory. On to this article.
Okay.
All right. So for the most part, what's interesting to me is that the oncology folks have paid very little attention to testosterone
Mm-hmm.
before or after their treatment.
Mm-hmm.
And so, for example, the average guy who goes to get surgery for his prostate cancer may never get a prostate testosterone level checked.
Okay.
Nobody cares.
Nobody cares because
They're going to get their prostate out, and nobody's shown that it makes a big difference in what you're going to do.
okay.
But now there's more and more evidence that low testosterone is a risk factor. Low testosterone,
Not high.
Exactly. So what these guys did is they had 350 men at, I think, 3 different sites who had prostate cancer identified and diagnosed.
Mm-hmm.
And they, for whatever reason, also got testosterone levels on them before they got randomized to different kinds of treatment.
Mm-hmm.
And there are 2 treatments. They both involved radiation. They both got androgen deprivation. One group also got another agent. They don't talk too much about that. If I read this right, there wasn't much difference in the results. But what they looked at with an average of 10 years of follow-up was how men with a testosterone level that was low compared to men who had a normal testosterone.
Right before treatment started, so when they were
Exactly.
diagnosed. This
Yeah,
was the measure of testosterone at the time of diagnosis.
exactly. And the surprising to some result, let's call it the surprising result, was the men with low testosterone
Yeah.
had higher mortality. More men died
Mhm.
from prostate cancer
Mhm.
or from anything. So we call that all-cause mortality or
Yeah.
prostate cancer specific mortality. Now, the data on and so that's the story. It's amazing.
That's amazing. So, in spite of how sort of this concept of testosterone causes prostate cancer, and many, many people would have predicted that those with low testosterone would have been protective of them, and then probably healthier at the end of the 10 years. We found the opposite.
Yeah, exactly. So this is the opposite of what had been taught for the last 80 years.
Yeah.
80 years. And, uh, the all-cause mortality makes sense. So we actually know that low testosterone is a risk factor for people. Those men die sooner than men with normal testosterone.
Mm-hmm.
We have solid data on that.
Mm-hmm.
And that could be for a couple of reasons, by the way, because other medical conditions,
Uh-huh.
almost all important medical conditions, are associated with lower testosterone.
Not because they're caused by lower testosterone, but they correlate.
Exactly right. So even when you're trying to adjust for things, as these studies always do,
Yeah.
obesity, diabetes, you try and make sure that you've got relatively similar amounts in the groups, or you do some statistical adjustment for it. You can never really be sure that you've captured everything. We call that residual confounding.
Mm-hmm.
So, so it's not surprising to me that all-cause mortality might have been higher in the low testosterone group, but the prostate cancer specific mortality, yeah, for sure. The authors in discussing this brought up something that also most people don't know,
Mm-hmm.
and it's a credit to them for bringing it up, but I'm not sure that I agree with their conclusion. So the PSA, which is the blood test that we get to help screen for prostate cancer, and most prostate cancers are identified because somebody starts off with a high PSA and then the doctor says, we have to investigate
Right.
this, right? So PSA is a chemical made by the normal prostate, but also made by prostate cancer.
Oh, I didn't know that. That's interesting.
And so prostate cancers tend to make more of it, or at least more gets in the bloodstream than people without prostate cancer. But here's the thing. The production of that chemical, that normal prostatic chemical, is influenced by whether testosterone levels are normal or low. So men with low testosterone, have lower PSA.
Uh-huh.
And when we give testosterone to men, if their testosterone is less than 250 nanograms per deciliter, which is in the low range, those men will see a rise in their PSA even though they don't have prostate cancer. This is normal men getting testosterone.
Uh-huh. Okay.
Whereas, and I'm an author on one of these studies, whereas if you start with a testosterone that's low but above that critical threshold of 250,
Mm-hmm.
PSA doesn't change. It's maxed out. That's part of what we call the saturation.
And why is that?
Model.
Why does the PSA not change?
Because at 250, basically all of the androgen receptors are bound to androgen.
Mm-hmm.
They're bound to testosterone or its metabolite, dihydrotestosterone, DHT. And once everything is bound, you can't really augment that system that much.
Yeah.
So what the authors here speculate is that maybe these men had a falsely low PSA because their testosterone was low.
Uh-huh.
And if their testosterone had been normal, maybe their PSA would have been higher
Uh-huh.
and they would have been in a higher risk group or something like that.
Ooh.
But the reason I don't agree with it is because the change in PSA tends to not be that much.
Uh-huh.
not that much, unless they have super low testosterone.
Mhm.
And there's no reason, I'm not sure that I saw what the numbers were. There's no reason to think that group has super low T.
Mhm.
Maybe one or two, a few individuals might. And rather, I think that there's something about the low testosterone state
Yeah.
that isn't good for the prostate
Or the body, based on what you're saying.
or the body, but specifically around prostate cancer.
Uh-huh.
Low testosterone isn't good. We have some data that having a healthy, robust testosterone level
Mhm.
or even higher levels keeps prostate cancer in check, keeps it well behaved.
What do you make of that?
So if we can forget for a second the old teaching that testosterone is bad for prostate cancer, where we are really then is that testosterone is a normal part of the environment,
Uh-huh.
of, of the chemical milieu, if you will,
Uh-huh.
for prostate tissue. Prostates start off as in boys before puberty. Prostate is tiny.
Mhm.
Puberty causes the prostate to develop because the prostate's part of our reproductive organs. It doesn't need to do anything before puberty.
Uh-huh.
Puberty is when the testicles start making sperm, they start making testosterone. Those things are related, and young boys undergoing puberty have the ability to have sex, have interest in sex, and can get somebody pregnant.
Mhm.
That's and the prostate contributes some of the fluid that comes out when a man ejaculates. So its design, if you will, if we can use that word, is around reproduction and sexuality.
Uh-huh.
The key chemical that makes that happen is testosterone.
Uh-huh.
So testosterone is not only a normal component,
Mhm.
it's also part of the healthy
Uh-huh.
environment. We have our healthiest or most robust testosterone levels. We, meaning men, forgive me, I don't mean to exclude you, but we men have our most robust testosterone levels when we are young.
Right. And that's when there's the least amount of prostate cancer.
Exactly.
I learned that from you a long time ago.
Exactly. So the whole story that testosterone was bad for prostate cancer never made sense. It was the strongest evidence of the natural history of testosterone that we have is young men never get normal prostate cancer. We call it adenocarcinoma of the prostate. Rather, it becomes highly prevalent as we get older,
Mhm.
and testosterone level is low.
You're right.
So that whole story never made sense. So what we're coming around to now slowly is that the oncology folks are beginning to recognize
Uh-huh.
that low testosterone is a bad prognostic factor for men with prostate cancer.
Yeah.
And we now there are even some strategies to treat aggressive prostate cancer that includes testosterone.
So this is a leap, I know, but can you question, is it possible that normal or higher normal levels of testosterone could help prevent prostate cancer?
I think that that's highly likely.
That's amazing.
I think that's highly likely. And more,
Wouldn't that be an easy study? Why isn't anyone doing that?
so, well, one has to be a little bit careful. So we do have studies that have looked at endogenous hormone levels, naturally occurring hormone levels, testosterone, DHT, and the risk of prostate cancer.
Okay.
Okay, and there's the two best studies are control arms of these other studies where everybody got a prostate biopsy.
Yeah.
That was part of the study.
Mhm.
Kudos, tip of the cap to the
Yeah, I
volunteers
was
who
gonna say, that's
participated in that
fun, man. I
study.
hope they got paid well.
And so in the control, both of these studies were designed to look at 5-alpha reductase inhibitors, these drugs that shrink your prostate on subsequent risk of prostate cancer. One of them was finasteride, the other one is dutasteride. But in the control arm, nobody got any drug, okay?
Okay.
And so, but everybody got a biopsy.
Okay.
And it turns out that the risk of prostate cancer didn't matter what your testosterone level was,
Okay.
with one caveat.
What?
In one of these studies, the reduced trial for dutasteride, although they didn't get drug, they looked at, so in other words, as you look at on one scale with testosterone levels, the rate of prostate cancer stays even,
Okay.
whether you're sort of low, medium, or towards the higher end of testosterone. But at the very lowest range, the lowest 10% of testosterone levels, they actually had lower prostate cancer. Now, they had lower, and I would argue because those prostate cancers were truly, so we all have a certain amount of prostate cancer, but if you're deprived, they're essentially deprived of enough testosterone for those cancers to do much. So it's not about the development of prostate cancer, but it's about whether or not you can find them and what their size is. Did I just confuse you?
Well, I think this is pretty complicated. Is it
Yeah.
complicated? I mean, there's a lot of different pieces to put together here.
So that story is about a snapshot in time, okay? Everybody undergoes a biopsy as part of this. Different story is what happens over time based on whether you have good levels of testosterone or low.
Right.
And there's not a lot of data around that, about following those people for a long time.
Okay. So, if we could put all this together, I'm hesitant to try to do that because we've covered a lot of ground. How would you summarize this conversation today?
Low testosterone is a poor prognostic factor, an adverse prognostic factor for individuals with prostate cancer.
And low testosterone correlates with all-cause mortality, regardless of prostate cancer.
Correct.
So if your testosterone level is below normal and you're living like that for a while, there's a better chance you're going to die of something than your neighbor with normal prostate.
Dr. Brandon, you were
Normal
brilliant.
test-
You are brilliant. You got it. You took it exactly to the right place.
Well, that's
You know what I love about what you just said
what?
is that almost everybody that talks about testosterone, and I think I'm affected by this too. We play defense,
Uh-huh.
right?
Yeah.
Say no, like there's this risk. Okay, but the data are reassuring. Okay, there's this. Okay, no. There actually is data that shows that it's healthy.
Yeah.
Healthful.
Yeah,
To
healthful.
have a normal, even a robust level of testosterone.
And healthful from a variety of mental health perspectives too, in terms of mood, in terms of fatigue, right?
Yeah. And on the flip side, death, avoiding
Yeah,
avoiding death.
that's
I think
big one
avoiding
there.
death is a pretty good sign of health.
I think right there, that might be enough to sell me. No.
Anyway, so that's the story. I think we're going to see more and more of this.
Yeah.
And it's my prediction. I think that we're going to see more testosterone used therapeutically in the future. We're going to treat people with prostate cancer with testosterone one way or another, with other medicines by itself. I think that's what we're going to find.
So I also have a question that may be going too far afield, but we're seeing some shift in testosterone levels of younger men, meaning testosterone levels are going down. We see more younger men with lower levels than we used to, right?
Yeah.
So that does make me wonder what impact that's going to have on their prostate health.
Oh. That's a really interesting question.
Yeah.
So, prostate cancer rates were steady for a very long time.
Mm-hmm.
The incidence, the new diagnosis of prostate cancer came down over the last 10 years or so. Starting, I think it was 2012.
It came down.
The number of deaths hasn't changed.
Uh-huh.
The number of cases of being diagnosed, but a lot of that is influenced by PSA testing.
Oh, I see.
And I believe it was 2012, if not, I may be off by a year or two, but I think it was 2012. There was this group called the U.S. Task Force on Preventive Services.
Mm-hmm.
They do all these evaluations of things like what's the benefit of mammograms or other kinds of tests.
Yeah.
And they came out with a recommendation, grade D, for PSA back then, which meant we think that the harms are greater than the benefits
Of getting your PSA level checked.
And what happened is a lot of doctors, especially family practice doctors, they bowed to the god of this U.S. task force and their recommendations.
Yeah.
And they stopped measuring PSAs in men.
Yeah.
So now it's coming back.
Mm-hmm.
And because what we're finding is this is an amazing thing. When I was in training in the 1980s, just as PSA was beginning to be introduced, so it wasn't really used yet, something like 90% of men who were diagnosed with prostate cancer already had metastatic disease. We had no way to detect it
Whoa.
early.
I see.
And so what happened is guys were never diagnosed. There was no blood test. They would show up one day in the emergency with terrible pain in their bones,
Yeah.
and it spread, or
Yeah.
they had nodal disease that blocked ureters or other things, so their kidneys got obstructed. When PSA came in after it was already in regular use, that completely shifted. And 80% of men who were diagnosed with prostate cancer had it localized, which means curable. And only 20% was metastatic. What happened after that U.S. task force grade D recommendation is that over the next 10 years, as they started following these men, the rates of metastatic disease went up. I'll never forget, I saw a guy when we were still living in Boston. I had my seeing patients then, and a guy came to see me who was relatively young. He might have been 60, and he had never had his PSA checked because his previous doctor didn't believe in it.
And what happened?
His former primary care doctor had retired. He had a new doctor, measured his PSA. His PSA was 800.
Oh my God.
And above 4 we think is abnormal.
Yeah.
So 800 is crazy high. He already had metastatic disease. This was an otherwise healthy guy, and he said to me, if I had had my PSA checked regularly, could this have been diagnosed at a point where it was curative?
Yes, is the answer to that.
Probably. Yeah, probably. So we're now finding more metastatic disease.
Okay, I have one more question.
Yeah.
So we know that low testosterone is correlated with all-cause mortality.
Right.
Is there a correlation with women? Is low estrogen correlated with all-cause mortality?
So the question is about whether women with lower estradiol have greater all-cause mortality.
Right.
But after menopause, which happens relatively early in the lifespan, relatively speaking,
Yes.
estradiol levels go down to essentially nil.
Right.
So you can't look at it that way.
Because it's such a small section of her life where her estrogen levels are so low. Is that what you're saying to me? And it's the end of her life? Not
Well,
really,
because so let's say menopause happens at 50.
Yeah.
Estradiol levels are low.
Yeah.
Women have a life expectancy of another 30 plus years.
Right.
So it's hard to look at that.
So chances are she's got all-cause mortality coming down the pike. Is that what we're saying?
But the question is about hormone replacement in women and whether that impacts
is protective in some way.
Yeah. So, and the studies I don't think have shown that.
Really?
Yeah,
That's amazing.
I mean, the biggest study is the WHI, the Women's Health Initiative study. Now,
Oh, of course I do. But I feel like what we hear is that estrogen is healthy for your brain and your heart. And
yeah,
I mean,
all true. But you know what happens as we get older? A lot of things are conspiring to kill us. So,
well,
I don't know.
A little sad. All right.
And on that upbeat note.
Yeah. Okay. Okay.
On that upbeat note, we'll end it there. And as always, it's a pleasure talking about testosterone and pretty much anything with you, Dr.
Oh, thank you, Dr. Morgentaler.
So thus ends another episode of The Sex Doctors. Check us out at thesexdoctorspodcast.com. Subscribe so you don't ever miss any of our fascinating discussions. And I had a good time talking about this today. Did you?
Absolutely.
All right. Well, hopefully you enjoyed it too, dear listener. And we'll see you again for the next episode.
Bye-bye.
Bye-bye.